So the simplest elements, of course, are the physical examination. And when lymphedema is established and at a certain threshold, a well-trained clinician can make this diagnosis at the bedside. We look initially for the presence of edema, which early in the disease will be pitting, and that pitting quality may be lost over time. We look for changes in the integrity of the skin, and there are early changes to suggest that the fibrotic response in the skin happens quite early and results in a loss of elasticity of the skin tissues, which can be detected on physical examination. And we also look for other elements in the skin, like the typical peau d'orange changes that represent pull and stretch on the pores in the skin structure based upon the specific changes of lymphedema. This, of course, presupposes that the condition is well established and also that the clinician feels comfortable in making the diagnosis. There are some objective studies that can be done. As I've already mentioned, measuring limb circumference or estimating limb volume can be done, particularly when there is unilateral risk, and this can be compared to the opposite side that presumably represents the normal baseline. But these limb circumferences are limited by the fact that they're both relatively insensitive to the presence of early disease and also based upon the anatomic variability that exists in all patients where there is a dominant, non-dominant variability present as well. It's sometimes difficult to establish what represents a threshold for the presence of disease. We also have objective measures that show us lymph function directly, and we would put in this category indirect radionuclide lymphoscintigraphy, which shows us dynamic function of the lymph system. And again, we would compare the at-risk limb with the normal limb. But this approach is both uncomfortable and costly and certainly not eligible for repetitive analysis in terms of prospective screening of risk, but certainly could be used to corroborate the presence of lymphedema once it becomes fully established. Those are the major widely used methods at the moment. I think the other method to be mentioned at this point, of course, is bioimpedance spectroscopy, which optimizes many of the attributes that are somewhat lacking in the other approaches. That is, it's quite sensitive to the presence of early or even latent disease. It can be done repetitively at low cost and with no inconvenience or discomfort to the patient. And in addition, it takes into account, based upon the databases that are available, the variability between the non-dominant and the dominant limb, so that it eliminates some of the concern about falsely either rejecting or accepting a diagnosis of lymphedema because the proportions between the dominant and non-dominant limb can be taken into account. Well, I think the other approaches that are used to any extent are typically used at least more commonly in a research context than in an active clinical practice. One is water displacement volumetry, as it's called, which relies upon the Archimedes principle that the volume of an object placed into a container of water will displace an amount of water equal to its own volume. And that is used, in fact, in a research setting and can be used to fairly exquisitely measure the volume that is displaced. However, it's a cumbersome method, and not everybody believes that it's entirely accurate insofar as it does require very precise methodology to immerse the limb in order to get an accurate measure. It has been used to a great extent in research studies, however. I just think it's a little cumbersome, a little messy, and a little difficult to do on a repetitive basis in this very large patient population. The other technique is pyrometry, which relies, in essence, upon a visual technique to make similar assessments. The problem there is that the expense of the equipment itself poses some concern. There has been some question raised about the absolute reliability of the data that is derived from pyrometry. And most importantly, both limb water displacement as well as pyrometry are making measures of the absolute volume of the limb and not really measuring the variable at risk, which is the extracellular fluid content. And I think therein lies some of the relative objection to using those methods to repetitively assess a patient who might be at risk for developing extracellular fluid accumulation.